uh, it is a pleasure to turn things over to Dr. Hamilton for the presentation.
Thank you. Just something so bizarre about someone speak about you. But thank you so much for having me. I'm really, really excited to be here. I'm going to share my screen. Okay. We all set? I hope so. Okay. I assume someone will let me know if you can't see anything. But I'm very, very excited to be here and really, really appreciative of the opportunity. I was saying just before this that I'm a big champion of MCAP. I'll mention in just a moment that having grown up in a place where there was a real deficit of access and opportunity for child psychiatry services when I moved to Massachusetts, and later when MCAP became more well known, it was something that felt quite revolutionary to me and is something that I'm a big champion of. So anything I can do to communicate my thanks and support, I'm very happy to do. Like mentioned, I'm Tessa Hamilton. I'm a licensed clinical psychologist. I've worked in a lot of different settings, but I work currently very happily on the adolescent inpatient unit that opened just over a year ago at, in Middleborough at McLean Hospital. And so a lot of my current work is in the context of the inpatient psychiatry setting. I am a New England transplant to New England. As mentioned, I'm a child clinical and school psychologist, but I'm a native of Arizona. And I often joke that my kind of earliest interest in assessment and child development happened with animals, and I became initially interested in animal child development. My parents are both healthcare professionals, but they decided to have a second chapter of life growing, raising their children on a ranch and growing all types of animals and raising beef cattle. And so that was a big shaping interest of mine, but also growing up so close to the US-Mexico border, migrant and mental health issues were a huge shaping influence for me and continue to be an area that, that influences my work in areas of interest. I have been in New England for 10 years, and I'll say is still, even after a decade here, the three things that I continue to kind of marvel at is the chokehold that the Dunkin' Donuts has on New Englanders. It's just something that, as a non-New Englander, that I don't quite understand. And it has been grown up in a place that has 350-ish days of sunshine. Being able, observing the ability that New Englanders have to be able to talk about the weather, no matter what the weather is another thing that I marvel at. And the kind of religious appreciation for sports, for New England sports that New Englanders have, is also something that I continue to observe. My goals here are really just to help enable and grow your understanding of psychological assessments and how they can be integrated into your work. And so, like mentioned, I really welcome any interruptions and how I might be able to add to anything I'm speaking about. Folks have such a wide range of held knowledge on this topic. And so if there's something in particular that you'd like to add on or ask a question about, please let me know. One of the classes that I teach for doctoral students is on the history of clinical psychology and psychiatry. And one of the more interesting things that folks get pretty engaged in is learning about the history of psychological assessments. We often observe that there is kind of a gap between the referral process, so the process of referring or recommending that someone should engage in a psychological or psychiatric assessment, and then that not actually occurring. And sometimes that's issues of access or wait time, but other times we can sort of observe that families are just having trouble making it there or a little bit hesitant. And something that I just think is important to note and hold on to for ourselves is that there are a lot of lived and historical experiences, that generational stories or lived experiences that families have themselves can contribute to that, and that it's important to have some awareness of it when we're making referrals. This is just a very broad stroke whirlwind tour. Initially, our first reported understanding of where assessments came from was from Imperial China, when they were using achievement tests to look at whether or not people had understanding of different topics enough to engage in leadership tasks. When universal education was introduced initially to France, and that's what we modeled our universal education of in the US, there was also a booming need to understand how to differentiate people and how to educate new people that were being introduced into the education system. And so that was really the impetus for educational testing. Benet has been cut off here in my little picture, but Benet was one of the earliest champions of this work and was the one that developed the Stanford Benet, which is still one of the most widely used intelligence tests. But the use of intelligence tests for universal education and in asylums to differentiate where people should go was one of the earlier uses of it. In the 1900s, the use of intelligence testing for the purpose of eugenics and forced sterilization became pretty widespread. Initially, this was predominantly used for white men who had intellectual impairment, but in the 1960s and 70s, it had booming use in populations of people of color. It was used as a systematic tool of oppression to rob people of their bodily autonomy. And while we often think about this as being something that's in the pretty distant past in immigration centers and in Native nations and in detention facilities, forced sterilization is something that has unfortunately continued into present day. The use of psychological assessments and the justification for the need of sterilization using psychological testing is something that is a held traumatic past, or a held traumatic experience for many particular communities. The Immigration Act of 1924 and the need to differentiate people and whether or not they would need intensive support services from the state is another area that we saw psychological testing increase. For many families, this can have, there can be generational stories of people being desperate for help or desperate for entry into a place of opportunity, and psychological tests or clinical tests being a point of challenge or a point of being rejected. And so those are also important to acknowledge or know the experience of. And then of course, the largest increase that we saw in general in psychological services in this country and around the world was in World War II, and then in World War I, and then again in World War II. And that had to do with so many new service members and needing to differentiate their skills and abilities. And again, when we think about the generational knowledge about what that can feel like to be tested, a lot of families can have the knowledge about the experience of going to war and being assessed. And so these are just important things to hold on to when we're making assessments and asking families about what their experience and perception of testing is like and how that may present a barrier. One of the largest kind of areas of challenge for folks is knowing if they're presented with a patient that they're looking for additional support about their psychiatric or psychological functioning, about whether or not a psychological assessment is more appropriate or a psychiatric assessment. And so I'm speaking about this in broad strokes because, of course, different psychiatrists might have a pretty substantial or abundant knowledge psychological assessment. And so there's always variations, but in the most broad terms, psychological assessments really help us answer questions about where a person's functioning across a specific domain or area of concern compares to same age peers. And so we use standardization, standardized measures, and normative comparison to help us understand where is this person, where were they before in their development, and where should they be relative to other people their age or relative to someone of their age if they were typically developing. That also helps us answer questions like, how might a potential deficit that we identify, so this person is this much below what we would expect a person of their age to be, how might that deficit be impacting their ability to engage fully in a life of choice, in activities of occupational engagement, adaptive tasks, socially, and what specific supports or treatment might be indicated for addressing those deficit areas over the long term? What are indicated empirically based treatment measures that might be most effective for addressing those deficit areas? By contrast, a psychiatric assessment, I need to move the little faces. Psychiatric assessment is most helpful for helping us identify how a functioning concern with regard to mood or cognition or behavior or perception compares with our understanding of known etiology and disorders. So we're seeing a cluster of symptoms or areas of concern, and we're comparing and contrasting what we know, for example, with ADHD or anxiety, and what we know about the etiology of where those disorders come from, which also gives us indications of both the course of immediate treatment and what might be most indicated in trying first, but also how that might be impacting someone's overall functioning. The thing that's most important to kind of distinguish is if we're looking for what is the kind of next step we should try, particularly with regard to medication, what's the most immediate thing that we need to try, a psychiatric assessment is most warranted. It doesn't necessitate a clear, very, very detailed, comprehensive understanding of the overall life course and the normative comparison of the symptoms. It just necessitates that we understand what is the overall picture of the symptoms that we see in front of us. What does that tell us about the direction that we should head in? And kind of what is the etiology that might be behind that, so we know what the most appropriate next step of treatment. One way that I try to kind of frame that for families is that I say, if we imagine your team here as a ship or aboard a ship, a team aboard a ship, then we really need a psychiatric assessment or a psychiatric provider to help us steer the ship in the right direction. So we're going in the complete wrong direction, that's just ultimately not going to be helpful. A psychological assessment is really going to help us chart the most appropriate, very detailed course. Where are we going next? Where are we going after that? But we need the psychiatric assessment to help just chart us in the most immediate and appropriate direction. Are there any questions before I move on just about this?
I don't see any, Tessa.
Great, okay. The overlap between psychological and psychiatric assessments is that both types of assessments help us understand a history of a presenting problem. We'll look for indications about personal and familial and social history. We'll conduct a mental status exam. We'll look at behavioral observations, and we'll conduct collateral contacts. What that looks like obviously looks different. So in a psychological assessment, it's standard practice to contact and be in to interview current treaters, to interview the school, to interview the family. In a psychiatric assessment, you may just conduct an interview with the family, depending upon the concern. Both will yield diagnoses and immediate treatment recommendations. The types of questions that would be answered in a psychiatric or psychological assessment also are different. So depending upon the type of question that you might be seeking to answer, the type of referral might be a little bit different, or which type of assessment you might refer to. So for example, if a question that you're asking is for a patient who's showing really a lot of difficulty engaging in their academic life, they're having trouble sustaining attention, they're not able to get their work done, they're not able to pay attention in class, we might be asking a question like, are these challenges that we're observing, this kid's not able to keep up with the rigor of their coursework that they used to be able to when they were younger, is that best explained by symptoms of ADHD, anxiety, or a learning disorder? That would be an indication for something like a psychological assessment. And maybe even for that same child, we might be seeking to answer a question about what types of accommodations or specialized treatments does this child need to access school and for their long-term psychological treatment. Another appropriate time to make a psychological assessment referral is when we might be saying, you know, this child has gone through a lot of treatment already and they are carrying several different diagnoses, some of which don't really make sense together, something like borderline and bipolar. So which one is most appropriate for this patient? That type of differentiation isn't necessarily required or isn't always necessary at the psychiatric assessment level, because it may or may not indicate the need for a change in medication, and it may or may not indicate what kind of where we're steering the ship, depending upon where a child is in where a child is in their course of treatment. But it is a really important question to answer for long-term treatment and for accuracy in identifying appropriate recommendations for long-term care. If we are seeking to answer any type of question about, does this necessitate medication management? What might this mean that this patient has had a sudden change in cognition or perceptual functioning and mood or behavior? Or how do we characterize these symptoms in an overall bucket? Like I said, how do we steer this ship most immediately? those are really warranted for psychiatric assessments. Both types of assessments can help us answer questions like, is this a psychiatric disorder generally? Are the types of treatments that are needed for a patient of these presenting with these symptoms beyond the scope that I can treat? Are there additional tests or referrals warranted? Those are all types of things. A question that often lingers for people, especially when you're working with children and adolescents so much in Massachusetts, is, well, what about school referrals and accommodations? Like, where do these fall? Are these better suited in psychiatric assessments or psychological assessments? And I'm going to talk a little bit more about this and hopefully answer that question. But my most immediate answer is that the best place to make that referral is to the school systems themselves. That's the most effective and easiest and quickest place that you're most likely to access and support the family in accessing school-based services. I'll talk a little bit more about that when we'll talk about psychoeducational assessments. There are, of course, a wide range of psychological assessments. The three biggest buckets that they fall into are psychoeducational, psychological, and neuropsychological. Within these, there's a wide range of types of measures that you might have heard used, terms thrown around before, but these are the three largest types of assessments. I'm going to talk about each assessment. Again, with the caveat that these are generally speaking terms, there's always variability, and there's an exception to every rule. But generally speaking, a referral for a psychoeducational assessment is warranted anytime you have a question about school and school-based functioning. The other thing that I often say to folks is, if this is a child that you think a neuropsychological or psychological assessment is warranted, but they have not yet undergone a psychoeducational assessment, always best to start there. The reasoning for that is because it's free. These occur at school and regional school districts. So these are psychoeducational assessments can happen in private pay settings, but they should always start, in my opinion at least, should always start at the local regional public school district. Even if you are working with someone who has their education in a private setting, they are still eligible and entitled to services, to special education services, including a psychoeducational evaluation and other evaluations of eligibility by their local regional school district. So the school district in which their parents pay taxes. That's something that families don't always know, but is important to help advocate and educate them on. I always say to start there because A, it's free and something that parents are entitled to, and B, because not every school district is willing to accept outside testing if they have not tested themselves. And if ultimately a child is going to require outside or additional psychological or neuropsychological testing, the testing conducted by a school district is often additive to what would happen later on. And that way that can just be supplemented in the outpatient setting at a much lower cost. These psychoeducational evaluations are at a function to tell us about what supports or areas of deficit are present in a child's ability to engage in their school and academic progress. And those might be areas related to learning or cognition, but also related to their social, emotional, or personality development. And then often they provide recommendations or indications of learning disability or accommodations that are necessary. They do not yield any type of diagnosis or whether or not a patient is eligible for a special education determination, but they do provide information that would be used for that process. Something else that's often not always widely known is that the vast majority of psychoeducational evaluations are conducted by certified school psychologists, which is a different level of licensure than a licensed school psychologist, and is often done at the master's level. Something I advise people about is that they vary considerably in depth and quality. I've seen some psychoeducational evaluations that are at the same level of depth and quality as a outside private pay neuropsych, and I've seen others that are really just a cognitive assessment and a screener. They always need to include two types of domains that are assessed. So typically that's cognitive and something else. I've included this mostly for your future reference because parents often look to especially to their medical providers for guidance about what to do when they're struggling with school. Something that parents don't often know and is often helpful to inform them of is that parents always have the right to request evaluation for a special education eligibility or a psychoeducational psychoeducational evaluation, they always have the right to request a reevaluation or to convene the IEP team to assess whether or not the current placement is eligible. Anytime that process happens, the parent has to request it in writing, and that process initiates a 30-day clock, 30 school day clock, in which the evaluation has to happen. And within 45 days, there has to be an IEP team meeting to assess the eligibility or need for a change in placement or services. Are there any questions?
Yes, Dr. Hamilton, I do have a question from Dr. Jennifer Casper, and I'll read it. It's really good. She says that she would like to clarify, have confirmation about whether there's specific language that needs to be included so that they can get a successful outcome in their request, for testing from the schools particularly. But I assume this also goes to insurance companies. And also, what are the legal requirements in terms of the prescribed time period that needs to be observed, for completing the testing. And then lastly, do the schools always conduct meetings to review the findings of these tests in the child and family's preferred language?
Okay, so the first part is about, is there specific language in the letter to request testing? So so that addresses an important piece. So one is that a parent, or legally the language says is that a parent or any educator that works with a child or any professional who has reason to be concerned for the child can put a request for testing or evaluation in writing. Obviously, with the caveat that in the case that you're working with a patient in an outpatient setting or in an inpatient setting or something outside of the school, you would need the parent's permission to do so. But the parent can do it themselves. There are letters, there are kind of templates for letters that I'm happy to share or send around to folks who are interested that are often helpful. But essentially, all you have to convey is your reason for concern, the specific things that you are noting that are areas of concern, why you feel like this impacts their educational development or their educational progress, and stating that you would like to request either whatever it is that you are requesting. So perhaps you're requesting a psychoeducational evaluation. So saying, I would like to request a evaluation for this child inclusive of a psychoeducational evaluation, or I would like to request a reevaluation of the appropriateness of this child's placement. As far as the exact wording, something that's important to keep in mind is that we have no jurisdiction over schools. And so the amount of times that I've gotten very, very hefty worded letters when I was working in the school, schools have every right to just throw the letters that doctors write in the trash or do anything that comes from anyone else outside of the school. So our best bet of success is to not write something saying that someone else in the school needs to do something, but to instead communicate our concern and wish to partner with the school. So I always say to communicate what you are observing, why you are concerned, what you think an impact this is having on the patient, and how you would like to help. If you communicate something like, you must do this, or this is what's necessary for this patient, the school has every right to ignore that. And unfortunately, that's what I've observed in the past. So that's my best suggestion. And then the other piece of the question was, so yes, they are legally required to complete testing within a prescribed period. So within 30 days, they have to legally arrange for or hold the testing. Arrange for means that they can schedule the testing within 30 days. So they don't need to actually do the testing, which is like a little bit of a loophole. They do always need to conduct meetings to review the report. Legally, school parents have a right to get the report 2 days in advance. Not every school district actually does that, but parents always can request it. So you can always advise parents of that. And do they do it in the preferred language? No, due to a lack of access. Legally, they're supposed to, but does that happen in practice? No, not always. So I think that's the reality of practice, but legally, yes, they're supposed to. And so if you happen to know that a parent is non-native English speaking, one way that you can be very helpful to them is to encourage them to advocate and write to the special ed administrator and say, you need to arrange that there is a translator in my native language present. If I didn't answer any aspect of that question or any others come up, please let me know.
I think you got it. Thanks a lot, Dr. Hamilton.
Okay. The other thing that I'd like to just mention briefly for doctors here is that if you have if you assess that a student is going to be out of school for 60 or more days due to an illness or psychiatric illness, or if they're going to be hospitalized for 60 or more days, you can also inform the school. And the special education administrator has the legal responsibility without undue delay to convene the IEP team and assess whether or not there is need to amend the IEP or change the level of placement for this patient. That's another part of the legal code in Massachusetts that's not often accessed because it's specific to doctors, but it's something that I often like to inform doctors that they have this legal right. Something else I often like to advise people help advocate families is that parents always have the right to disagree with a school's evaluation. They can request an independent evaluation, but schools do not have to accept outside evaluation. So sometimes families will say, I'll just get an independent evaluation and then I'll use that to get an IEP. And sometimes that is a counterproductive process, which is why I always say, if we haven't gone to the psychoed first, let's not progress yet to a psychological assessment, especially because of accessing means. A psychological assessment also assesses many of the areas addressed in a psychological assessment, but the focus of the referral question is broader. It's not just looking at their educational functioning and how they do in school, though that's one of the areas of concern, but it's also looking at their overall ecological engagement in their life, and it's looking at their development course. How do the problems or areas of concern that we're seeing, how does that compare with other areas that we've seen develop over the course of this child's life, and how do we project that might look differently as they continue to develop if they do or do not receive treatment. The focus or the area where this typically happens is in outpatient or hospital clinic settings. They're typically in a insurance-based system. You can private pay for these, although it's quite costly. It happens through a licensed psychologist. One of the sort of tips or tricks that I often recommend to referring providers is if you have a clinic that you like to work with, often hospital-based clinics are typically pretty helpful because they have a pretty wide panel of providers that are conducting the evaluations. And once you find a couple of providers, a couple of psychologists that you like that are doing the assessments, be in contact with them and ask if they also have a private practice, so that if the wait time for a particular patient is exceptionally long, you could also encourage that parent to contact that psychologist's private practice if you know that they're appropriately suited to evaluate that particular area. If they specialize in ADHD or something and have a private practice, that can often be another way of working around wait times. The wait time can be exceptional, and when I was working and doing outpatient neuropsych evaluations, that was really some of the hardest time period, is that you were doing evaluations for families that had been referred. Sometimes this was in the pandemic times, sometimes that had been referred 2 years ago. It's very, very hard. The outcome, unlike a psychoeducational evaluation, is going to be a differential diagnosis, making treatment recommendations and more long-term recommendations. This is not the place to refer if you're looking for an immediate recommendation, or if you're trying to inform what medication you're going to recommend right then, because it's such a long process and the wait can be so long. This is, again, just to give, I'm not going to go over this in depth, but just for your reference of the types of measures that can be included in a psychological assessment. The difference between a neuropsychological assessment and a psychological assessment is that oftentimes the focus of a neuropsychological assessment is understanding more neurological or neurodevelopmental components, or how medical conditions might be intersecting with psychological conditions to impact a patient's functioning. Practically, and neuropsychological assessments always have to include some aspect of assessing neurodevelopmental or neurospatial aspects of functioning. So it has to include things like executive functioning, processing speed, cognition, memory, or attention, in addition to the psychological components. Practically speaking, in our managed care world, neuropsychological and psychological assessments occur almost interchangeably, and they're almost indistinguishable from each other. A neuropsychological assessment is always the place to recommend if you have a patient with complex medical conditions, with a traumatic brain injury, with a neurodevelopmental condition, who has a developmental condition, or if you're really trying to understand the focus of the scope of their developmental or neurological processes. Just want to pause for questions before I go on. I'm going to differentiate this a little bit more.
Tessa, the only thing I would point out, when in terms of neuropsychological versus psychological, and you can speak to this if you have a different view, is that insurance companies usually prior authorize neuropsychological testings, but often they don't even have any kind of authorization process for approving psychological testing, so that it's much easier to get that, especially if it's not necessary to use the neuropsychological measures for some kind of central nervous system disease process or injury. That it might be good to start with psychological. Do you agree with it?
So it depends on the insurance company. So in Massachusetts, we have a standard form that we use for pre-authorization. And so it depends on the type of insurance company and the type of plan that they have, how willing they are to authorize. So yes, they are always more willing to authorize psychological testing than they are neuropsychological testing, because the reimbursement rate is much lower for psychological testing. So that's always the reason that the completing evaluator wants to get neuropsychological testing, and always the reason why the insurance company is trying to advocate for just psychological testing. Essentially, the difference in what they're willing to authorize for is whether or not there is an inclusion of aspects of things like executive functioning, and this is in practice, that what they're willing to authorize for comes down to things like, if you are including measures of executive functioning and more traditionally recognized neuropsychological measures. So those are things like the developmental neuropsychological assessment, looking at visual spatial functioning, looking at their memory and attention, and using multiple measures to look at that. They usually are pretty willing to authorize that. It's just some companies are more or less stringent. And you're right, some companies are willing to pre-authorize the testing itself. So they'll give you a certain amount of hours for neuropsychological testing. Other companies are willing to only authorize some companies are willing to authorize the testing and the amount of hours that it'll take to test and score. And other other insurance companies will only authorize for the administration itself. They're all much more stringent with neuropsychological testing. Practically speaking, it doesn't totally matter what the referring provider makes the referral for. Ultimately, it's going to be the completing evaluator who's going to submit for authorization. So whether or not you make the referral for psychological or neuropsychological doesn't entirely matter at the insurance level, because it's the evaluating person, or depending upon the process at the receiving clinic, it's typically the evaluating clinician or someone at administrative level with input from the clinician who will decide what measures. Does that make sense?
Totally. Great points. Thank you.
So just like I said, in the real world, most people try to get neuropsych. One thing that's helpful to just know is that there is an emerging interest or subfield within the field of psychology, is that people become board certified neuropsychologists. And that means that after post licensure, so once they're licensed as psychologists, it's just like completing a specialized fellowship within medicine. They complete a specialized fellowship in neuropsychology, which is a 2-year supervised fellowship, and then complete an additional board certification. In an earlier time, there was some thought that that insurance companies would only authorize if someone was a board certified neuropsychologist. We haven't seen that come to fruition, and the vast majority of people who complete neuropsych evaluations are not board certified neuropsychologists. So you don't have to look for a board certified neuropsychologist to do a neuropsych evaluation. Again, this is not something I'm going to go into in depth. This is just for your own understanding of how does a psychological assessment differ from just a clinical interview or a psychiatric assessment. There are specific core principles of a psychological assessment that they have to have multiple areas of input, that they have to have psychometrically sound procedures and psychometrically sound measures that we're using, that we need to use some type of norm reference measures, that we're never using just one measure or one piece of data to make an informed decision, that we're selecting tools that are appropriate for the referral question. Those are all aspects of psychological assessment and all reasons that you might want to make a referral for a psychological assessment. I just leave these here as what I call honorable mentions. So these are other types of evaluations that you may see in a psychological assessment that are not as entirely as common, but are pretty relevant. You might hear achievement or aptitude tests, which are just essentially how well are you able to do something to the level expected. So that's on a particular subject area. So for example, math. There's occupational or career inventories. Forensic evaluations are important to know about because anytime you are wondering, what is the level of risk that someone will do something bad in general terms? But so if you're saying, this person is voicing homicidal ideation to their mom, I'm going to refer them for a psychiatric assessment because I want to know, how likely is it that they're going to do that? No psychiatrist or psychologist who does not have training in forensic evaluation can give you that information. That's an appropriate time to refer for a forensic evaluation. Those are folks who are appropriately trained to give you that. Behavioral assessments or antecedent-based assessments or FBAs, functional-based assessments, help us understand what is the function of a behavior? Why is someone behaving in the way that they are? And those may be components of evaluations. And then sometimes the types of evaluations that we refer for are multidisciplinary evaluations or developmental evaluations. So these are when multiple types of practitioners come together and they each from their respective areas of domain. So when I was working in Salem at the MGH for Children there, we had an MDAC, a multidisciplinary evaluation center, where the psychologists would evaluate, the speech and language pathologist, the occupational therapist, and it gives a comprehensive understanding of a child's development at that point in time. This is, again, just a resource to help you to carry with you in your ongoing work, that there are times where we often think is this a potential area of concern? And sometimes psychologists or psychiatrists are the best resources of referrals, but there are often other types of practitioners that can provide really helpful indications. I often think of occupational therapy when there have been referrals made to me and a patient has really, really concerning traits of sensory processing disorder. I often make a referral for an occupational therapist. And so that process can be truncated of the wait to see me and then me making a referral if the referral is made directly from the original referring provider. Physical therapy, sometimes referrals can be made for things like toe walking, which is always something that we should be concerned about. It's a fun fact, if we ever notice toe walking in early development with children, that's always something that we should be concerned about. It should always be a red flag for autism and should always indicate a referral for further assessment. And so that's something that we might want to immediately refer to a physical therapist in addition to an additionally trained provider who can evaluate for autism. BCBAs or psychologists trained in behavioral analysis, like I said, can do FBAs. Something that's important to note specific to autism and FBAs is that there are certain types of access and opportunity, sometimes in school settings, sometimes in outpatient settings, that are not eligible or not available to people if they have an autism diagnosis that did not come from a licensed psychologist through a neuropsychological evaluation. Even if a psychiatrist has provided that evaluation and given them the label of autism, that diagnosis through those means does not always enable people to get services that they may really need. So it's important to make sure that we're not referring for a psychiatrist to conduct that evaluation if we are trying to enable autism-based services if a person does not yet already hold that diagnosis through a comprehensive psychological assessment. Certain types of access and opportunity, certain types of services have access and opportunity holds that are really dependent on evaluations that evaluate their cognition, their adaptive functioning, and their social emotional skills. Those have to be conducted by licensed clinical psychologists. And there can be really difficult conflict points that families get into if a psychiatrist or pediatrician has already given them the label of autism, but they haven't yet gotten it from a psychologist, because the insurance company will then not authorize the neuropsychological evaluation, saying they already have the diagnosis. So it can become a conflict point. So if you're at that point of saying, I'll just give this diagnosis, I'm sure, it's a good point to ask whether or not it might be worth making the referral. Often in those situations, it can be really helpful also to refer to speech and language pathologists, especially if we're concerned about ruling out a social pragmatic disability or a language-based learning concern. There are obviously other specialists in medical rule-outs that we might want to be concerned with. The 4 or 5 questions that I often encourage people to consider before making a referral is what the purpose is for the patient undergoing the evaluation, both considering the rigor of the process and what you don't yet know that you hope an evaluation is going to answer, and providing that information to the agency where you're making the referral. You cannot make or do a good evaluation if you don't have a good referral question. Asking yourself which professional is best equipped to answer the question and complete the evaluation. Being able to ask yourself whether or not the family that's involved in this referral process has been advised about the access opportunities in their local public school system or other areas that may enable them to access different opportunities. How you will use this information in your ongoing work, and whether or not there's a need to refer for more immediate evaluation. So obviously, if there's a safety concern or a need for more immediate medication, a psychological evaluation is never the place to go, because they're going to wait on a wait list for a pretty long time. And what additional support or education might be necessary for this family to access this? Things like translation concerns that was mentioned, which is a great point, or things like what we mentioned about the history of psychological assessment and how that might be difficult for this family. I don't know why this looks so weird, but a most important thing of all when making this evaluation is that to keep in mind is that evaluations are only as the quality is absolutely dependent on the quality of the referral question and the specificity of the referral question. And so really being thoughtful about that process before you make the referral is key. These are, again, this is just a resource for you to hang on to. These are strong referral questions and weak but understandable and common referral questions. These are some guidelines for when you're consuming reports. Again, I don't typically go through these in great depth, but I know a lot of folks, especially if you're a referrer for evaluations, you get these very large packets of information, and they can be pretty daunting. The things that I always caution folks about is that to remember that this is just a moment in time, that evaluators ourselves are human. Again, this is a fact or something that I advise people to keep in mind, is that sometimes you may have had the experience, or you may not, or will eventually have the experience of seeing a different patient's name in the body of an evaluation than the patient that you are reading about. If you notice that more than once, I would caution you to not take any of the information seriously within the rest of the evaluation, because it's almost impossible to discern if that was just an error or if the actual data about the patient itself is also incorrect and was copy and pasted from another patient. I would really strongly advise folks to keep in mind the age of the patient you're considering. And I say the expiration date for any evaluation is much, much shorter, depending upon how young a patient is. So the younger the patient, the much shorter expiration date. You never want to use someone else's evaluation to inform your care without a substantial amount of your own evaluation. So it's just one piece of data and use your other data. And you also want to evaluate and consider what substantial events or information has been obtained since the evaluation occurred. Anything greater than 2 to 3 years is just background information, but should not be considered a portrait of how this patient is currently functioning now. When you're actually looking at the report itself, The first thing to look at is the date of the report. Like I said, the shelf life is important to consider. The setting the report was conducted in, or the evaluation was conducted in, and consider whether the evaluator might have had a vested interest in the outcome. So in schools, that's a potential bias. To look at the developmental history and background, that's often a very rigorous and helpful area that's conducted in psychological reports. To look at their behavioral observations, that's one of the most overlooked parts of evaluations, but it's through the lens of what this person thought was most important to note about the behavior they observed. And then finally, to just go to the evaluation interpretations and summary. Every evaluator knows that this is exactly where everyone goes. We focus most on putting our most interpretable language in this section and summarizing the most key and pertinent information. So I included some additional notes, and I'm always happy to answer questions, but those are the key areas that I encourage folks to think about. I thank you very much for your time and attention. And the last thing I noticed that, like, with tremendous gratitude for the work that you all do for children and adolescents throughout our state, I also, as the child of a doctor myself, I am always thinking about how difficult the work of doctors are and how many doctors lose to suicide and to mental illness in this country. And so I'm always encouraging folks to work themselves, to taking better care of themselves and of one another and of our medical trainees who work very hard. That we have a responsibility to take care of ourselves as much as our patients. I'm happy to answer any questions.
Nice point, Dr. Hamilton, about physician wellness. Thank you. This has been really great. I see just one little hanging sort of piece of a question that Dr. Casper had asked before. She was wondering if parents can bring someone with them to help with translation, since the schools are not always, going to be providing translators for these sessions.
Yeah, I think for a number of reasons, I would say that that's not something to advise against by any means, because even if a school provides a translator, as I'm sure folks have been experienced in the medical setting, there still is a linguistic or cultural divide often about the information. It can be helpful to have someone that someone's familiar with to help with both a linguistic translation, but also just comfort in the situation. Whether or not the school will consider that an official translator is dependent on the district. And that certainly doesn't fulfill the school's responsibility to provide a translator for that patient and family. And I guess I would just add the caveat that if the school is really just not providing translation for the family and is relying on the family bringing their own translator, I would have greater concerns about the family's support and ability to access other means within the school. So I think I would continue to say yes and advocate with that family about their rights and to advocate at the school district level that they need to provide translation.
Great.
Tessa, you skipped over that slide about good and bad questions. I wonder if maybe that's worth us seeing.
Sure. So strong referral questions, like examples of referral questions that are really, really helpful to address, are things like, these are just examples, like what might be contributing to difficulty sustaining attention. ADHD remains one of the most common questions about ADHD differentials. It's one of the most common reasons that someone might refer for a neuropsych or psychological evaluation. So asking a question about, like, what is the locus of the attentional concern? Oftentimes we say that if these are long-standing issues, then we're really more concerned with understanding a potential attention deficit. If something has emerged much more recently with regard to attention, that's often an indication of anxiety. And so that would be a good referral question. What is contributing to it? Is it anxiety or an attention concern? And what types of educational supports? If a patient was experiencing emotional reactivity and a tendency to feel rejected, does that indicate a potential mood disorder or versus a personality disorder? And what might be some treatment approaches? That would be another example of a helpful referral question. Questions that ask for the best way of characterizing challenges, things like sensory sensitivity and repetitive thinking have a lot of crossover with things like OCD and ASD. And so asking for the best way of characterizing that is a great referral question. Trying to understand how emerging challenges in a particular area like impulsivity, if they are best suggested by one disorder or another, what types of supports would be most helpful, what might be contributing to challenges that we're observing. Those are all areas that are strong and wonderful referral questions. Very common, very understandable, but not super helpful referral questions are things like, one of the most common ones that I've seen is just diagnostic clarity is the referral question. And it's hard to know if exactly how to focus the clarity for the diagnosis. My impression of what clarity might look like is different than yours. Knowing what you are having trouble teasing out is really helpful. Another area that is very understandable and common is saying, these are very, very demanding parents. What I'm providing is not enough. They just want more, and making the referral ultimately, unfortunately, this is a process that isn't going to make them feel more fulfilled. Anytime there's a concern about something like a change in mental status or psychosis, certainly there can be aspects to a psychological assessment that can be helpful, but we would want to refer for a psychiatric evaluation first. And like I said, level of risk questions are best referred for a forensic evaluation. Any questions about any of this?
Yeah, well, there's actually a couple of other questions that have come into the chat and the questions sort of function. One is about parents who would like to seek an independent evaluation if they're not satisfied fully with the evaluations provided by the school. And do you have any advice about how to access that kind of thing?
Yeah, so I first would help the parents clarify why they want to seek an independent evaluation. Is it because they're not satisfied with the services? They don't agree with the evaluation. They don't feel that the evaluation that was done was fair. And really try to understand the locus of the impetus for the seeking of the additional evaluation, and ensure that seeking an independent evaluation is actually going to address those areas of concern. For example, oftentimes I've heard parents say, I'm going to go seek an additional evaluation when I ask for, or they've come to me for a separate evaluation. And in reality, what I'll advise is what they need to do is convene the IEP team and advocate for a change in placement or for additional services. And there's really no need for an additional evaluation, but they do need support in that process. Legally, there's legal precedent, or there's legal information in Mass law that schools can pay for the cost of an outside evaluation. There's a process for that, and that process can be very difficult for parents to kind of navigate, because you have to sort of go through an evaluator that is equivalent to the district, and that it has to not be, exceed costs. And so oftentimes parents just want to pay for an evaluator that they find themselves, but you should and can advise parents that legally they are entitled to schools paying for an alternate evaluation themselves, and that they should pursue looking into what that process is like, and can the school help them with that. That's what I would encourage them to do. But again, I would start with why they're looking for this and what they hope this will achieve. And to just keep in mind that the school does not have to accept the opinion of an outside evaluation. Like, that won't be held necessarily to a higher standard.
Yeah, and then the insurance won't pay for it if it's for educational purposes, even though that whole issue about educational versus life, for a child, it's not so clear cut. Sometimes you can sort of frame it as not, exclusively an educational issue if you want to try to get it authorized. There's one other question. I think there's time.
But that's a great point just to keep in mind, is that making an outside referral for purely a school-based concern is not likely to be part of insurance. So there needs to be an additional concern.
Right. So I guess there's time for one more, and there are two questions, but we'll sort of send it to you to see if you can respond. But it's about the FBA. You mentioned, functional behavioral assessment, and most commonly, I think, is used for people with autism spectrum disorders. But I guess the question is, I'm not certain what the precise angle of the question is, but FBAs, can they be used for people without autism, and who does FBAs, and how does one access them?
So yes, FBAs can be used for people without autism. For example, I've conducted FBAs in our setting to assess like what the antecedents and consequences and function of a behavior for a patient experiencing substantial difficulty is. They can be conducted by, predominantly, I would say, in schools. They're conducted by BCBAs or someone who has behavioral training to understand like what are the things that happen before and after behaviors of concern. I'm happy to talk more if someone has specific questions about a particular patient, but I would say when you're seeing repetitive kind of patterns of behavior and you're trying to understand like what links all of these, an FBA can be helpful. And there are lots of different people in the community. I'm happy to answer any more specific questions about that.
Well, thank you so much. So I think we're going to have to close, and we will send you the last remaining question that was asked. But thank you so much, Dr. Hamilton. It was really informative and helpful. And the slides, just as a reminder, the slides will be available on the MCAP website with permission from Dr. Hamilton, and so you'll be able to access those. But thanks again, Dr. Hamilton, and thanks everybody for attending. It was great.
Thank you.